faculty of medicine because I'm just the chair of the international exchange committee of the faculty of medicine. So anyway, probably you know that where our faculty is. We are now here. It's a private campus, but our medical campus is located in the eastbound of Kagawa City area on Miki Town. So now this shows the first and 2 years of the faculty. It has 3 schools: medicine, nursing, and clinical psychology. Especially notably, this clinical psychology department has launched very recently in 2018. So we accommodate about 700 medical students. It's a 4 years bachelor course, and 4 years nursing course. We accommodate about 270, and the clinical psychology course it's accommodate only 20 students per year. So now I believe that it should be 80. This year just bit old, and also we have many grad students. Most of them are international students, and also we have faculty members and staff members. And this shows the bird's eye view of our campus. This was shared by the University Hospital and the Faculty of Medicine located side by side. It's very convenient for us. And we have many helicopters, regular helicopters, to accommodate the patient from the isolated islands by helicopter. And of course, we have Starbucks cafes, It's very good point for us. And this is from the brief history, but I'd like to avoid reading this long pages, but the Faculty of Medicine, as a young faculty, it was established about 40 years before, in 1978, as an independent Kagawa medical school. It's an independent school, just different, cover the whole area of medical science, and also much number of the clinical departments that were there. So every kind of disease will be covered by this clinical department. But to catch up is a very cutting edge aspects of the medical science, and to meet the local medical requirement, we established some temporary devoted funded laboratories. We have now the 9 departments. Usually such a temporary laboratories last 5 years, at least 5 years. But if needed, most of these departments last longer, probably more than 10 years or 15 years. And in the nursing department, you have 12 groups, and also in the department of clinical psychology, we have many courses that can cover the whole area about with regard to the clinical psychology and basic psychology. And we have the affiliated hospital named Kagawa University Hospital. It's established in 1983, and now its official bed is, I cannot find the number, but it's have the 613 bed. It has been recently renovated for part of our hospital, so it's very clean different from our department as a whole. But we have many cutting edge facilities like them, and also we have the training facilities for the medical doctors or nurses or other co-medicals. So we call this facility as a skills lab, and there are many medical simulators there. For example, it's the dubbing simulator, it's a very famous, the robot operation machine, and so on. And one of the Kagawa University Faculty of Medical Medicine characteristics is that we strongly engaged in the international collaboration activities, for exchange activities. So we have many close friends, very close friends. Especially, we have close ties with the Chiba University, Thailand, and also University of Dar es Salaam in Brunei, and also in California we have friends in University of California Mercer campus, and also in China we have close ties with Hebei Medical University. We all, before the COVID-19 pandemic, we sent many students to this Hebei Medical, and also some of very excellent students study at Newcastle University or University of Glasgow in Scotland, and also the St. George's College at the University of London. So we usually send, before the coronavirus pandemic, about 30 students, dispatching students, and accepted about 30 or 40 international students from our friendly universities. So this shows the list of the fiscal year just before the COVID-19 pandemic. This shows the list of the dispatched short-term students, and also, initially we sent much more students, but part of them, the visit of part of them were cancelled by COVID-19.
So I'm Dr. Jan2022 from the faculty of medicine, Kagawa University. My second year in Kagawa University, but I've been in Japan very, very long time. This is my 20th year in Japan. 日本語のコメントが欲しい方いらっしゃいますか？英語だけでいいですか？ Anyway, there are some slides with Japanese explanations. So I'm from Congo, DRC, the Democratic Republic of Congo, Central Africa, and I got my medical license at the Kinshasa University, the #1 university of Congo, DRC, very long time ago, 1997. And then I worked for the UN Refugee Medical Project, maybe you know UNHCR. So I took care of refugees from Angola, from Rwanda, and I worked in these Central African countries for almost 4 years as medical doctor. And I also worked as a lecturer at Medical Science University in Kinshasa, Songwa University. I also worked as a so I did epidemiology in Bordeaux, France for 1 year as a training. Second University that have public health school over there. And I wanted to start my PhD course at Kochi Medical School earlier, but my Japanese level was 0. I couldn't speak Japanese, so nobody could take care of me. So I waited. Then in 2007, I entered the public health department of Kochi Medical School, like as a researcher, supporting the staff and doing research with them. And I took my entrance exam in March 2008. I got the best score, so they allowed me to get scholarship. So I studied for 4 years, PhD course. And after graduation, as I received some awards, Best Researchers of the Year, and one of the President of Kochi University President's Awards. So I worked for 2 years as a Kenkei researcher at the medical school. Then I moved to the local university, Kochi Keirichi Daigaku, for almost 4 years. In 2008, I moved to Narita. There is a university over there, Kokusai医療福祉大学 International University of Health and Welfare in Narita for 2 years. Then I came to Kagawa. So I moved back to Chicago. So my topic today is about association COVID-19 and NCDs. NCDs is what we call in Japanese country. So I'm proposing a public health approach that may help to improve COVID-19 response. So to prevent a severe COVID-19. So this is my plan. First, I will talk about the epidemiological profile of COVID-19 and the risk factors that causes severe COVID-19. Number two, COVID-19 and diabetes. That will be my main points of the day. Why people having diabetes, suffering from diabetes, are among those who are very high risk for hospitalization, even to die from COVID-19. And what is the relationship between high level of blood sugar and SARS-CoV-2 infection? Then the last point, proposing an approach to addressing COVID-19 response. I prepared one slide for a short self-introduction, but maybe it's no more important, so I move to the first point, epidemiological profile of COVID-19 and risk factors for severe COVID-19. So the figure shows the area of the world that are that have a very high COVID-19 incidence rate. The red parts are those countries with high, or regions of the world with high COVID-19 incidence. So I just picked data from WHO and CDC in the USA. So worldwide, since the beginning of the pandemic, there are about 312 million cases reported worldwide. Of them, over 5 million of patients died from COVID-19. In the Americas, North America, South America, until yesterday, I think, there were over 114 million cases, of whom over about 2.5 million deaths. It's very, very high. In Europe, about 114 million cases, of whom 1.7 million deaths. In the African continent, we have quite less, 7.5 million cases, of whom about 160,000 deaths. And the situation in Japan shows that we have until now about 1.8 million cases, of whom only 18,000 died. And what is quite astonishing is that there are several preventive measures that are being implemented in all nations of the world, including mass vaccination. But the prevalence of COVID-19 is not that low, it's not decreasing in many countries. In Japan, it decreases. But our neighbors, Koreans, in Korea, South Korea, they have still high incidence of COVID-19. In the US, in Europe, we have a similar trend. Why this is happening? So I will explain later. For example, we have the emergence of new SARS-CoV-2 infections with variants. So the same virus can try to use its defense mechanism. It can change the same virus, but changing some of the genes to become either more aggressive, more virulent, sometimes less virulent. So since the beginning of the pandemic, maybe you heard about the Beta and Delta variants. Delta got famous with the big epidemic in India. Then it's spread all over the world. And now we're talking about Omicron variant. So there is a difficulty to control the pandemic in many parts of the world. And we're going now to show some facts that are happening in some countries, especially in Europe and in the USA, which shows that most of the measures used are not able to control the infection. So we need more research, more studies to find out what are the risk factors that are leading people to die, to get hospitalized, or even those who are already vaccinated getting reinfected by SARS-CoV-2. There are several studies from Europe and the USA showing that doctors, as you know, from medical staff working in hospitals, almost 100% of them have to get vaccinated against COVID-19. But even though they are vaccinated with 2 or more doses, some still get reinfected. For example, in the US, in Europe, European hospitals, New England Journal of Medicine has reported in several articles cases of occupational COVID-19. That means COVID-19 occurring in medical staff. So similar reports were also found in International Journal of Tropical Medicine. This is our report. A study conducted in Congo in 23 hospitals in 2020 was published last year. And CDC USA also reported almost 19,000 hospitalization and also death cases among healthcare workers already vaccinated against SARS-CoV-2. In Japan also, there are some cases of clusters of COVID-19 in medical staff. The case of Okinawa, some medical staff got infected after getting vaccinated, and they could spread the infection even to patients and families of patients visiting their relatives in the hospitals. So what are the risk factors that expose people to develop a severe COVID-19? This is a study conducted, a review study conducted by a group of Japanese researchers that was published in 2020. So they gathered research data from 17 studies to compare those studies which risk factors were associated with COVID-19 in the US, in Europe, in France, in England, in Japan, in China, etc. So those studies all show that age is strongly associated with severe COVID-19. It means elderly people from 60, 65 years of age are at higher risk of developing severe infection. So 100% of those studies incriminated age. CRP, C-reactive protein, which is very known as an important marker for inflammation. So people who have high blood level of CRP protein, because they have an inflammatory disease or because they have another infection, they are also at high risk of developing severe infection with SARS-CoV-2. LDL cholesterol, in Japanese we say akudama cholesterol. The LDL cholesterol level, high LDL cholesterol level is considered for all those studies has a very high risk factor for severe COVID-19. Smoking. We all know that smoking is one of the common factors for several chronic diseases, particularly NCDs, seikatsu kankyo. So among NCDs, non-communicable diseases, these are chronic diseases. Which one are considered as high risk factors for severe COVID-19? We have diabetes and hypertension. So all the studies show that diabetes and hypertension are most prevalent in people with severe COVID-19. I will focus on diabetes later because there is a very strong relationship between high blood sugar and severe infection. Also, chronic kidney disease, CKD, is also revealed as one of the high risk factors, and cancer and other cardiovascular diseases. So hypertension is among cardiovascular diseases, but we just separate because some in the research they separated those two disease names. So people suffering from all those diseases, even people who have what we call cardiometabolic risk. For example, those who have high BMI, so getting fat or become obese with BMI over 30, those who have metabolic syndrome, so they are also at high risk of developing the disease. So this is a study published in 2020 showing the relationship between diabetes or high blood sugar, hyperglycemia, and severe COVID. So, the two products that are selected in red here shows the risk of severe COVID-19. For example, here, people who have already diabetes, they are already known as diabetic, and you have people who got COVID-19, then they were diagnosed with diabetes. So for those who already have existing diabetes, the risk is this 1.55 1.6倍 risk factor. But those with new diabetes, the diabetes discovered, diagnosed during COVID-19 infection, they have somebody some high risk of developing severe COVID-19. This is for unadjusted analysis about the analysis of research data. After, in the same study, after adjusting for age and sex, which means you want to eliminate the influence of age and gender, still the risk remains high. In those with newly diagnosed diabetes, knee for those with non-diabetes. So this study shows that diabetes is one of the high risk factors to develop severe COVID-19. But the problem is that many people do not have the habit to go to hospital for medical checkup. So many people don't know if they have high blood pressure or high blood sugar. So when they get COVID-19, this will be discovered in the hospital. So it's a very high risk factor. We need to know our status, health status. Whether my BMI is getting high, whether my blood sugar is getting high, whether my blood pressure is getting high, then I can take measure to change the situation, to reverse the situation with some dietary measures or treatment in hospital. Then we can avoid if we get COVID-19. If we are exposed to the virus, we may not develop the disease or we may not develop the severe disease. So the relationship between COVID-19 and diabetes. So what are the mechanisms that lead to severe COVID-19 in people who have high blood sugar or who already suffer from diabetes? So this slide summarizes everything. I will show some figures for the mechanism, but this is very simple summary of what I will show you later. So many organs of our body have what we call receptors, ACE receptors, around the cells, for example, in the lung. So AC2 and TMPRS2, they are proteins. They are like carriers. They facilitate the entry into the cells of some microorganism or some nutrients after eating or after a virus or bacteria enters in the body to get into the lung, to get into the liver, to get into the pancreas. They need that protein to carry them into the cells. So SARS-CoV-2 virus uses those two receptors around the cells. They bind to the cell, then they get in and start to multiply. Those cells are well expressed in lung and pancreatic cells. So in the lung, in the pancreas where insulin is produced, we have many ACE2 and other receptor, which means when the virus enters into the body, it will be easily for the virus to get into the cells in the lung, in the pancreas, and other organs that have a lot of ACE and TMPRS2 receptors. especially beta and delta variants of SARS-CoV-2 virus. For Omicron, the case is different because Omicron doesn't use these receptors. So it stays around the throat. It doesn't go into the lung to cause pneumonia. And the virus will enter into the cell, replicate, and then multiplies. After multiplication, the multiplied viruses will invade the bloodstream and be dispatched to different organs. So after entering into the cells, the virus SARS-CoV-2 in the lung and in the pancreas will cause what we call necrosis. So it will kill the cells. After killing the cells, for example, in the pancreas, we have what we call beta cells. Beta cells are those that produce insulin to bring the balance regarding insulin. After producing insulin, the body should use insulin to lower blood sugar. But if those cells in the pancreas are destroyed, it means our body cannot, or the pancreas cannot produce enough insulin. So the result is that the blood sugar, after eating, blood sugar will remain high. And this status of high blood sugar is one of the high risk factors that will lead to severe COVID-19 if the person is infected. So by infiltrating inflammatory cells, the virus also aggravate the inflammation because it is an infection which causes inflammation in different parts of the body. So by entering inflammatory cells, the virus contributes to triggering inflammation because the inflammatory cells will start producing what we call inflammatory markers, which increase the severity of infection. So, number one, we have hyperproduction of cytokines by inflammatory cells. And the technical term used in medicine is cytokine storm. A lot of cytokines will be produced to aggravate inflammation. Second, reduction of production of insulin because cells in the beta cells in the pancreas are destroyed by the virus. So you have status of hyperglycemia, high blood sugar. So these two phenomena will aggravate the disease. So what I just explained is shown in this figure with different stages. For example, here you have all the markers related to cardiovascular system, the heart and blood vessel function. So all those markers are increased and they will damage the blood vessels and blood viscosity will be increased and you may have heart disease and vascular disease, CVDs. And in the other parts, inflammatory cells are invaded. They will increase inflammatory markers like IL-6, and this will lead to aggravation of inflammation. And because of inflammation, you may have what we call insulin resistance. You may have your insulin, but the body cannot use that insulin to decrease the blood sugar level. Hyperglycemia. So inflammation may cause hyperglycemia. Destruction of pancreatic B cells will also cause hyperglycemia. And you have damage in the lung because of the inflammation. So pneumonia will be aggravated, and the disease, COVID-19, will be aggravated because of hyperglycemia or newly induced diabetes. About diabetes, the situation is summarized here. You have someone who does not have COVID-19 infection and someone who has COVID-19 infection. There is effect on beta cells in the pancreas, I explained. You have effect of systemic COVID-19 infection, which will increase stress response, the cytokine storm that I talked about. And also, during COVID-19, in a patient, in the treatment, sometimes they use steroids. Steroids are some drugs to reduce inflammation. And they have a side effect of inducing hyperglycemia, high blood sugar. So, impaired insulin sensitivity or induced hyperglycemia because of this treatment. And beta cell damage, destructive, that also leads to increased blood sugar level. So this is the new onset of hyperglycemia or diabetes. It's a kind of diabetic syndrome created by the virus.